Well, good morning, everyone. I do want to thank you for having me here today. There is one rule, and that is that we have to be comfortable, and that includes me. So I am taking off my shoes because that's how I think best, when I'm comfortable. And feel free to take off all your shoes. You may do that. Just a little history of how I got to where I am. Some of you may know a woman named Maggie Thomas who attended in Flint, Michigan, long-time member of the church, and she developed pancreatic cancer. She did not have any family and no children, and so our family became her family. Maggie lived with us twice, once when her house burned down, and the second time when she was diagnosed with this horrible disease of pancreatic cancer. The last 3.5 months of her life, she lived with us, and she actually passed away in our dinette area. And it was a good experience, but a bad experience, because being on the other side of the bed, we got a real good feeling of what it's like to not know what death looks like and how to handle it. And so when Maggie died, I decided at the tender age of 48 that it was time to go to nursing school. I became an RN, and I have worked with hospice now for many, many years. And it's been a wonderful thing. It's been a sad job, but it's been a very good job. And if I had $5 for every time someone said to me, "What do you do?" And I said, "I'm an RN." And they say, "Well, where do you work?" And I say, "I'm a hospice nurse." And they go, "Oh." It is a sad job, but it's a good job. I love it. And it is probably one of the most rewarding things. But it's something that we don't want to talk about. We don't want to talk about what it's like to no longer be here, to even think in that direction. And so I think that it's a blessing to be here today. I'm really grateful for the opportunity. We'll be talking about several different things. We're going to talk about advanced directives. We're going to talk about what dying looks like. We're going to be sprinkling throughout this conversation, having the conversation, because this is not something we like to talk about. And I think that this is a very important topic. Now, we're going to leave this world in one of 4 ways. We're either going to have a tragedy, and that's going to end our lives right away, or we're going to have frailty. We're going to live a long time and just kind of wear out. Or we're going to have cancer or some other disease. That is how we're going to leave this world. And that is something, again, we don't talk about, the what ifs, the hows. So now that you know I'm a little ray of sunshine because of what we're going to talk about today, I will be looking at my notes, forgive me for that, because right now, with all the bright lights and everything, I'm going brain dead. But death is something that happens to everyone, and we're not going to avoid it. It is just one of those things. But we tend to not prepare for it. We prepare for all kinds of events in our lives. We present ourselves the great opportunity to go to the feast, and we prepare for that. We prepare for our children to get married, new jobs, retirement, all of these things we prepare for. When up in Michigan, I survived the polar vortex of 2019, thankfully, but we prepared for that as well. We knew that the bad weather was going to approach, and there we are. But we don't prepare for the end of life. And this is what we need to do. So, apparently you have to turn this on. There we go. So these are the topics that we're going to talk about. Hospice 101. What is hospice? What is palliative care? Because those are 2 things that we have in this country now, but you know what? One of the things we don't like to talk about is the H word. We hide behind the word palliative, and both of them are comfort, but they're different. We're going to talk about the advanced directives and what does death look like, and how we can provide support before and after the death. Because when someone dies, they don't just die once. In our hearts, they die over and over and over. We remember that. It's a keystone. So What do these words mean? We'll start out with the hospice versus palliative care. And again, we postpone these discussions until we're right at the end of life. But we're not preparing our children. We're not preparing ourselves. One of the questions that I often get asked when I go in to talk to a family whose loved one is now going to be placed on hospice is, how much time do I have? And I have this little pat answer that I hope gives them a little comfort. And I say, you know, I have seen a lot of people, and I've seen them completely unclothed. I've never seen an expiration date on anybody. I don't know. But what we have to be prepared for is the what if, when it happens. And sometimes it's very quick. Sometimes we don't know. And it reminded me of that verse in Ecclesiastes 9:11, that unforeseen circumstances happen to us all. But unlike other events, we aren't prepared. So we need to integrate palliative care into the mainstream medical care and separate it from hospice, because they are two different things. This quote here was from Donald Schumacher. He is the president of the NHPCO, and he's really a great guy. But when we look at death in the United States, we have a lot of high-tech ways to keep you alive. Not necessarily the best way to keep you alive, but we have them. And doctors actually don't choose to die the way that we do. Many doctors will not take the same treatments that they provide for us. It's just not part of that way that they want it to happen. This is how knowledgeable some of our doctors are. A few years ago, doctors couldn't tell you what palliative care was at all. In fact, one doctor, when I talked to him about why he doesn't refer people to hospice, he said, well, when I don't talk about it, he says, it's because I don't want them to know that I failed. And I said, well, when you don't offer them the services that is available for them, you have failed. Because you're either going to die with some knowledge or you're going to die afraid. And most people will die afraid. I went to a conference, an emergency palliative end-of-life care training, and there were 3 nurses and 197 doctors from around the world. And it was very eye-opening because one of the things that doctors wanted to know, they wanted 4 breakout sessions. 1, they wanted to know about pain management. And that is something that we in hospice do all the time. It is not our gift to be able to give enough medication to kill someone. That is not what we do. We do not euthanize, but we do make people comfortable. That confuses physicians. It really does. They wanted one on pain management. They wanted to know how to talk to a person when their disease was going to be termed terminal. They wanted to know how to talk to a family when someone was going to be dying or has died. And they also wanted to know, and this one what really floored me, they wanted to know how to recognize a dying patient, how to look at this actively dying person. And I thought that that was just fascinating, that they would ask those questions, but that's how little they knew about the dying process. We have over 225 universities that pump out our physicians. And we're doing good because we're offering elective classes on end of life, but they're only elective. There's nothing on the state boards, that's a 3-tiered system. There's nothing on those state boards about end of life. That's how unprepared we are, but we can medicate it like crazy. So we do have a lot of treatments. Heart disease, we can't cure it yet. It's the #1 killer in the United States. COPD, we can't cure. And it's going to be elevated to the lofty position of #3 in what kills us in this country. Diabetes, we can't cure it, but we can control it to some degree. Cancer, some of those things we can cut out and we do very well. Some of the treatments work, but it's a very tentative position on some of them. We can't cure Alzheimer's. We don't even know exactly how Alzheimer's happens. And as a dementia practitioner, it's quite fascinating to me to see what we really don't know about this disease. Parkinson's we can't cure, kidney disease we can't cure, and stupidity, we can't cure that either. But there are some, like I said, some forms of cancer that really do well. My grandson has leukemia, and he was diagnosed when he was 5. The cancer treatments for that are just fascinating. The children are managing to live a little bit better. They do have some recurrent cancers, but we can treat it to some degree. Breast cancer we can do quite a bit with as well, depending on when we catch it. With Alzheimer's disease, I want to go back to that for just a second because they said, we don't really know. Pfizer actually just pulled out of all Alzheimer's research, and they're now going into neuroscience research because 95% of everything that they have tried has failed. So we can't cure that one. But I threw this in because it actually is what we do in this country. When I was a nursing student, it was kind of interesting because as a nursing student, no matter what you know, you can't say it. It's up to the doctor. And one of my patients was an elderly gentleman, and when I walked into his room, of course, my experience having someone die in my own home, I knew what death looked like. So when I was walking in, I saw this man that was in that state, and his wife was sitting over on the windowsill crying. I said, "How can I help you?" And she said, "Is my husband dying?" I said, "What makes you think he might be dying?" Because I couldn't say yes. And she said, "Well, he's not eating, he's not talking to me, all of these things." And I put my arm around her and I said, "I'm sorry that you're going through this. I know it's got to be very painful." And she laid her head on my shoulder and she wept. And I got in trouble because she was not my patient. I got in trouble for touching someone that was not my patient. But aren't we supposed to have compassion? For this gentleman, rather than the doctor talk to the wife and tell her what is going on, they instead moved him up to a different floor and put him on life support. 3 days later, she had to make the decision to have extreme measures stopped. How emotionally trying was that for her? And again, this is because we don't know how to talk about it sometimes. Doctors are there to cure us. And it's great when they can, but that doesn't always happen. So the good news is, because of all the treatments that we have, we are living a lot longer. Sometimes we're not living better. We can extend life for a long time. And again, it was just talking about the conference that I went to in Chicago for the training for emergency palliative medicine. It was very fascinating to me what we hide from. We have those conversations, or at least we don't want to have those conversations. So this is the way we have things going here. 200 BC, eat this root. Say this prayer. As time goes on, you see where we came. And now we're back to eating the roots. I did have someone tell me, however, that she could cure Alzheimer's disease with essential oils. No, not going to happen. But okay. But here's the other thing. We talk about all of these other cures, but have you had an end-of-life conversation with your physician? Anybody? Here's how mine went. You had one. Excellent. She's the only one in the room. But doctors are actually paid $86 for a 30-minute conversation with you about dying. And $75 every half hour after that for the longer the conversation goes. And yet we don't have the conversation. Here's how mine went. I think my doctor's ready for me to go. He said, "Andi, who's going to talk for you if you can't talk for yourself?" And I said, I don't know. He says, "Here, fill out these papers and make sure I get a copy." 2 minutes, but not very meaningful. We need to have more meaningful conversations because when we get sick, our future looks way different than it ever did before. It will look different not only for ourselves, but also for our loved ones, for those that care for us. When we look at this chart, this is about the fixed income. We have a lot more people that are going to be that baby boomers. And let me tell you, we are going to be an interesting breed to take care of in the future because I know what I was like. And it's not going to be a whole lot different. But when we look at this, you got to consider also that Medicare is looking at a 5.6% increase in medical expenses. Now we've got an aging population. It's going to cost more for these treatments. And who's got the money, especially if you're on a fixed income? And trust me, baby boomers did not save like the World War II generation people did. We're not prepared for all of this. So this is where I think that we need to look at having better discussions at an earlier time about palliative and end-of-life care. I really think that's important. This group that is looking at what's happening in the future, we're looking at the sandwich generation. We have kids who are taking care of their own family, possibly their grandchildren as well, and older aging parents. What's happening to them? Now we have another group that's going to have a lot of stress, and the situation is going to be very difficult for them because what we know about stress, it can cause heart disease and many other things that are going on. So again, how old would you be if you didn't have to die of a disease? Any idea? They actually projected this out, 567 years, if you just wore out. Anyway, so looking at palliative care, this is for a person who has a disease and they are taking curative treatments. Palliative care is oftentimes given to people who have cancers, liver diseases, heart diseases, kidney diseases, all of these things. And they're taking these curative treatments that are sometimes giving them pretty sad outcomes as far as nausea, pain, et cetera, especially your cancer patients. And this is where we see a lot of that. There are three main goals of palliative care is to treat the person, not the disease, and also to not necessarily extend life, but to maintain function. And then the third thing, of course, is minimizing suffering, but not just for the patient, but for the families as well. And this is the other thing. If it's palliative care or hospice care, we need to integrate that family into everything that's going on. Because when you're the one left standing at the side of the bed, things change. They change rapidly for you. Now, sometimes palliative patients will stay on palliative care until just days before dying. And then they'll transfer to hospice care, which is a little bit different. But when you have the person's on palliative care, you can still go into the hospital. You continue the treatments that you were having before, and life goes on. But there is a difference. We'll talk about that in just a few minutes. The problem is that when we're taking all of these treatments, sometimes we lose those good days. And we want to focus on good days. There is a chart that you have that discusses palliative care right next to home care and then hospice care. It's on the second handout that you got there. And that gives you a pretty good breakdown, and we'll refer to that chart in just a few minutes along with what we're talking about here. This is what hospice care is. Hospice care is that care that is going to be for that person who has a terminal condition and they are not seeking curative measures. Now, this is where it can get a little bit dicey, because everybody thinks that if you go on hospice and you have dialysis, that you have to stop dialysis. You do not. If that is your primary thing, then yes, you do have to. But if you're on hospice services for a cardiac condition, you can continue with the dialysis treatment. It isn't a matter of stopping treatment or continuing treatment. You can be ready for one service, but not be ready to die. Because if you're not ready here and here, you should not be on hospice services. Palliative care is where you belong. And I had some hospice people that said, well, that's just crazy. You're not even telling them about what we do. No, it's about keeping hope alive when it's reasonable. And only you know what's reasonable for you. But if we don't talk about the services, then how are we going to do it? Now, cancer was one of the primary reasons that hospice came into our country. 1972, I believe it was, that we actually started offering hospice in the United States. And it was primarily cancer patients at that time. But we do everything from AIDS to a disease called Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is tumors that form in the pancreas. And 50% of the time, people will pass away from that because it becomes cancerous. So as you see, we encompass everything now. But it was just cancer when it started out. We do focus on quality of life rather than cure. And as you know, sometimes you can take away quality of life by what we take away here and here. That being that we have, the things that are important to us. And that's not something that we ever want to do. By the way, hospice does treat infections. And we go where the patient calls home. I myself took care of a homeless man in a house that was derelict in the city of Flint. And that was freaky. But that's what he called home. And he was one of our charity cases. But when it came to the point where we had to give narcotics to this man, then it was no longer an option for him. He either had to go into a facility or we were going to have to back off, because you can't be running around in the city of Flint with opioids in your pocket. It's not going to be a good thing. You'll be real popular with certain people. But deciding what path to take really is a personal preference. And again, we have to have those conversations. Your spiritual belief. And when I talk about spiritual belief, it's not just the patient's spiritual belief. Sometimes we have to think about the people that are in their home. They may not believe like we do. As a Sabbath keeper, we might be living with people who are absolutely opposed to Sabbath keeping. So we have to take that whole group into consideration. Emotional preparedness, I already discussed that, but financial ability. And this is where we kind of move things around just a little bit, because palliative care, I'm going to try to do this very easily. Palliative care is one of those things that if you have insurance, most insurances will cover palliative care. But if you have insurance, many of us have a deductible. If you have a deductible, you will still have a deductible under palliative care. And that means deductible for medication, equipment, etc. Some of your equipment will not be paid for by palliative services. So there is a big difference there. One of the other things that isn't on this slide, but education, is we need to talk about what palliative is, what hospice is, but also the right to try. And that is a new thing. I believe it was May of 2018 that act was actually approved as Bill number 204, I believe. 41 states have that now, which means that if you have a disease process, you have the right to try medications that have not yet been approved by the FDA, which can be a big problem because you don't know how those things are going to react with your system. But it is an option now, which is kind of interesting. You can't have any clinical trials when you're doing any of this medication. But who are we, again, to take away their desire to try? There is a family that I'm very well aware of, very well acquainted with, that have a son who was diagnosed with spinal cancer, and the tumors went to the brain. They wound up seeking alternative treatment because under traditional medical care, he was going to die. He is now 25 years old. He's not doing great, but he's alive. And that is so important to his family and to him. He's not ready. Not everybody is going to go the same route, but they did try the right to try thing, which is great. Dr. Brzezinski, I think was the doctor's name. He's a wonderful guy. So this is where an apple is not an apple. Both of these services are about quality of life, and yet we want to make sure that it is family-centered and person-centered. One of the things that really shows what an apple is not an apple, and you can come on and off hospice services, you can come on and off palliative services. Palliative services were designed for a short period of time to control the symptom that is making you sick, and then you go on into regular traditional care. So it's really a time-limited thing. Hospice, we put someone on that has a life expectancy of 6 months or less if the disease runs its natural course. And yet, not everybody expires in that 6-month period. So what Medicare has built into that is that every 2 months after a person is on hospice and they've met that 6-month criteria, every 2 months we recertify this individual. And people actually get better sometimes on hospice. They really do. It's quite amazing. But Medicare pays 100% of all hospice. There is no deductible. There is never a bill sent to that family, ever. Most insurances do the same thing, but we do not charge for hospice care. Families going through enough. But I talked about you can actually come on and off hospice services. There was a lady, she was 93 years old, and she was undergoing a lot of issues with her heart. And it was interesting to me that they continued to go on with palliative care, doing surgery that Medicare would pay for, but not give her the palliative services because her insurance, the way it was working out, wouldn't be the case, wouldn't pay for it. It was very strange. But we need time to step back and look at different things. But again, insurance deductibles are going to be there with palliative care. When you look through that side-by-side comparison that I gave to you, you see that with palliative, you're going to have a nurse or a physician that will come in and visit with you. The nurse generally comes in once a week or once every 2 weeks, depending on what's going on. With hospice, you're going to have a nurse that's available 24 hours a day. That does not mean that she's going to sit by your side. It means that if you need somebody at 2 a.m., trust me, I was on call a lot. And if you needed somebody at 2 a.m., we got there and we took care of your need. On palliative care, most of the time they will tell you to go to the hospital. So it's, what do you want here? The other thing is that with hospice benefit, you're going to have a full spectrum of caregivers that are going to be there. You're going to have the doctor and the nurse, the CNA or the aide, spiritual care, and you're going to have social work. We have volunteers. We have all kinds of things that are available to you. And again, there is no cost to you for that. So, see, I could have just flipped this slide and there it would have been. But again, you have that in your handout. I'm not going to belabor the point. But you see that there are different ways that this is going to impact you if you have a little bit of money and you need to retain that money. Hospice is actually a good option. And one of the other things with hospice, you do not have to be a DNR. And I have been to quite a few homes where they had maybe switched from the hospice service that they were on to this hospice service, or they're even interviewing, because just because it says hospice, that does not mean that it's one service and it's going to be the same. You have to interview people. For palliative and for hospice, interview. Know who it is that's going to take care of you. Because this particular hospice said that unless you were a DNR, they couldn't put you on services. That is a violation of your rights. Again, you have the right to have whatever kind of medical treatment you want. And we know that CPR is not necessarily going to be the thing that's going to sustain you. So you do not have to have that. Again, I encourage you to look at that comparison tool. Again, when you look at the goals of the patient with the disease, we have to have these conversations early. It is so sad when we hide behind words. Palliative is one of the words that we're hiding behind rather than saying you have a terminal disease and we're going to put you on the services that might be best for you. But you don't know what's best for them if you don't talk to them. And we hide behind that word palliative because palliative means comfort. Hospice also means comfort. But I thought it was very interesting because Canada actually changed their word for hospice to palliative care because palliative meant that this was care for the derelict people. And you're not derelict, obviously. So they used the term hospice for over 100 years and then they switched it to palliative because we want to, it reminds me that scripture was speak smooth things. But we need to talk about some things that are really difficult sometimes. When we talk about these two services, we're talking about emotional, physical, and spiritual care. Both of them have to have these. And it's a very big component in hospice care. So there are differences within the programs. Educate yourself. One service is going to be obviously a lot more appealing than the other, depending on where you are, but don't avoid talking about hospice. Nobody wants to talk about dying. This is a hard thing because from the minute we're born, we're beginning that journey to death. It's what happens in the middle that's going to make the difference. But when we say palliative versus hospice care, sometimes it's too encouraging, giving false hope. We need to be honest about what's happening. One of the doctors that I had an issue with was an oncologist. And he would always ask for Andi to go out and see these families. And I found out why very, very quickly, because he didn't tell them that the cures that they were hoping for were not going to be, and that it was probably time to end their chemotherapy treatments and talk about hospice. How would you like to be the person sitting in the chair and they did not even know that the doctor was thinking in this direction until you came in? That was a horrible situation to be put in. And we cried more than once with families. And some families did not want to come on hospice services. And they sometimes didn't want to right away, but eventually they did. And when they did, they wanted to be with somebody who talked to them honestly, openly. These conversations can be scary, but they're very needed because we're not going to change the outcome. But we can change the outcome to some degree to create more acceptance, less fear. Does anybody have any questions, comments? No? Sir?
You mentioned DNR a while ago.
Yes.
What is that?
I'm sorry. You know, as a nurse, I talk nurse. And DNR is do not resuscitate order. Do not resuscitate, do not intubate. And then they have another one called VSER. And that is voluntary stop eating and drinking. And they actually will talk about that in a little bit in the next session, perhaps. Okay? Yes?
You mentioned that there's no bill for hospice, but does hospice receive payment from Medicare, from the insurance company, but the patient never has to deal with that?
Right. Good question. Yeah, hospice, the way that it works is that for every day a person is on hospice services, They get paid a certain amount. Now, hospice, they just reformatted that, so you actually get paid more in the beginning, about the first 2 weeks, and more at the end. But it's during this middle that you actually are taking a dip in payment. Out of that payment, because it sounds like hospice is a great racket to get into, but it's not. When you think about they get this much payment, let's say that they get $150 a day. And depending on where you are in the nation, it's going to change. So they get paid $150 a day, but out of that $150, you pay all of the staff, you pay for the medical equipment, you pay for the medications, you pay for wound care supplies, you pay for anything that they need. And so that family never gets a bill. Sometimes hospice has a little bit of a profit, but most of the time, we're just kind of eking through, as evidenced by the number of people who say, why don't we hire more staff? Because sometimes we can't hire more staff. Depends on how many patients we have and what's going on. But that's how hospice is paid. When you are on palliative care, if you've gone in for a test or you've gone in to get medication, you have that copay to take care of for most insurances. That includes Medicare. Any other questions? Yes?
Yes. It's not on? Mm-hmm. It is on, okay. So what would you give as advice for someone who's trying to, whose loved one is not quite to the point of not doing treatments, but are heading that way? What could one do to prepare, or what could they do themselves?
Well, I think first of all, we need to know where they are, what their goals are. Because again, I said, when you're diagnosed with a disease process, life looks different to you. So what do you want to accomplish in this time that we have? Mom, Dad, do you want to stay at home? Do you want to take that trip? That's a time for fulfilling all of those goals in life that we may have had, creating memories. But they're going to, some people accept things because they think sometimes we go to the doctor knowing something's wrong, and then the doctor confirms it. So now, okay, we've got a name that's going to go along with this. So some people have had an opportunity to deal with some of this emotionally already, but others haven't. You get blindsided. There was a gentleman down in Texas recently. He had a lot of pain in his shoulder, and he went to the doctor, and he had a fast-growing tumor that he didn't know he had. He thought he had strained his shoulder. And it turned out that he now has an incurable, fast, very aggressive cancer. So he has had very little time to think about this. But sometimes as we age, we know that we're going to have to make some decisions along the way. But it really is so individual. For us, I think that we need to be prepared for tears and anger because they know that this might be the end. And some people are not ready. And this is where they get a little hostile. One of my patients got a terrible prognosis from a disease, and he decided to retreat from everything. He lived down in his parents' basement where it was cold and dank, and he wouldn't let anybody come and visit him. And I turned out to be his nurse, which was his biggest problem in life, I think, because I'm a hugger, and I always tried to build rapport with my patients, with my clients and their families. And I said, Doug, just want you to know that every time I come in here, unless it's a real problem for you, I'm a hugger. And he said, you can't hug me. And I said, okay, what's your personal preference? And then he started to cry. And he said, ever since I was diagnosed with this disease, nobody's wanted to touch me. And I said, you know, Doug, I'm not afraid that I'm going to catch your disease. But what I am afraid of is that you're going to be lonely and scared. And I don't want you to be that. And he said, then give me a hug. I said, okay. So we hugged every time I visited him after that. But it was really sad because sometimes that's what happens. People have a harder time adjusting to things because now they have a diagnosis. And then people don't know what to say to them. And so it's a protection device for us, so we don't go in there and visit with them as frequently because we don't know what to say. We don't want to hurt their feelings. So it's easier to not address it. And that's not helpful. And that, again, goes back to the conversations. You know, I'm sorry this happened to you, Sue. Is there anything that I can do for you? Remember, we were going to go take that trip down to the Creation Museum. Let's do it. So, you know, we have an opportunity to actually build relationships and help them come to terms with some of this that's going on. Any other questions? Or did I answer your question that you were asking? Because sometimes I get around going flibberty-gibbet, you know. Okay, well, if we don't have any other questions, I think we can take a break and then we can go into the second part of this. I hope that this was enlightening. If you do have any questions, or if you don't understand it, please talk to me. Okay, thank you.